Okay, so I think we're ready to start. So dear audience, welcome. My name is Mariangela Pellegrini. I'm the Educational and Patient Program Manager for the ERN-EuroBloodNet European Reference Network on Rare Hematological Disease. And it's my great pleasure to welcome all of you today on behalf of the ERN to today's lecture that is the fourth webinar of the program named Topic on Focus on Sickle Cell Disease for Patients and their Family. As you may know, this program is a cycle of webinars, and it aims to disseminate important topics related to sickle cell disease to the patients' community and their families. And so we are going to talk about the last advances in terms of treatment, diagnosis, improving the quality of life, and so on. It's important to underline that all the topics of this program have been chosen by people living with sickle cell disease themselves, as they have answered to a survey when they have prioritized the educational needs. Before officially starting this lecture, I would like first to share some house rules and technical information. So as you are seeing, this session is recorded because it will be implemented in our educational channel on YouTube and our e-learning environment, also on our website. So if you don't feel at your ease with the camera on, please put it off. And also be kindly informed that your microphone will be muted along all the presentation, but you have the possibility to write the questions in the chat, because at the end of the lecture, there will be the question and answering session. So the possibility to answer to your questions or comment, feedback, whatever you prefer. So as said, we can go through today's topic. So we are going to talk about neonatal screening. This lecture is led by Professor Béatrice Gulbis. Well, first of all, she's the co-coordinator of the ERN-EuroBloodNet, so I'm very honored and pleased to have her with us today. But she's also a physician specialized in clinical biology. She has developed a reference laboratory center for the diagnosis, prevention, and follow-up of patients with hereditary red blood cell disorder. She's responsible of neonatal screening program in Brussels region and has been working for its extension at the national level. She has also contributed to the implementation of national network of health professional non-oncological red blood cell disorder through the Belgian Hematology Society. And also she works a lot with patients community and patients advocates, and also on grants for research projects in Africa like Burkina Faso and Democratic Republic of Congo. So please, dear audience, welcome with me, Professor Gulbis. Please, the floor is yours. Thank you very much.
Thank you very much, Mariangela. So, good afternoon. Even if I don't see each of you, I'm very glad to share my knowledge, and I hope I will be able to pass it to you, and so you can spread it to other colleagues, friends, children, or whatever. And we really wanted to speak about neonatal screening because it's something very important in the life of any patient with sickle cell disease, to get a diagnosis, a final diagnosis, but the way could be the screening. So I will explain what means screening, because sometimes it's something different because you understand about diagnosis, but there is also a matter of screening. I also would like to share with you the understanding of the purpose and the benefit of this neonatal screening. And finally, for whom, how, and where the screening is offered. And of course, then it will be open to a discussion. Yep. So what means screening first? You see, we would like to offer. That's something important. Offer means it's not mandatory. You can refuse to be screened for sure. But it's to offer it to a group of people who are not apparently ill, affected by any disease, but who are at risk for it, for any condition, because the screening might be for other diseases than sickle cell disease, and so they can be tested. So in a group that has to be defined, we would like to find the one who has a positive screening. Of course, it means that you might have false positive. So it means that as soon as you are screened positive, you are offered more tests to make the diagnosis, the final diagnosis of the condition, and for sure to enter this individual affected by the condition into a comprehensive care. So the comprehensive care might be quite different from one condition to another condition. And then we can come back a long time ago. It was given by the World Health Organization in 1968, and they just gave us the principle and practice of screening for disease, for any disease. So what are those criteria? First, the disease must be a serious public health problem, because screening is for a group. You don't focus on someone, it's for a group. So it must be a health problem, and so at the national level, we will take that into account. You have also to understand the natural history of the disease. So you have to know when the disease will begin, what can be done to be sure that we have more signs or symptoms of the disease if you give a treatment, for example. You must also detect the disease at a pre-symptomatic stage. It means that you can say, yes, this individual is affected, but it's not too late to give a treatment or to do anything. The treatment has to have proved its efficacy, and it's applicable to the patients. You have also to have appropriate means of diagnosis, and the treatment of patients are available. Maybe you know that there is a treatment, but it's not available at the level of the country, for example. You must also give the possibility to have an effective screening test, and it's acceptable for the population. If you have to cut your hand to have a diagnosis, it's not acceptable for the population, of course. And you must have a precise therapeutic protocol. So you know for whom you will give a treatment, for those who won't give a treatment, for those you can wait a certain time, and so on. Since you provide this opportunity, you offer this opportunity of screening to a certain amount of the population or all the population at birth, for example, in neonatal screening, there must be an economic cost-benefit ratio. And then the sustainability of the program must be ensured and evaluated. This means that you said, okay, I can screen the condition, then I can, if there is a positive test, I can make the diagnosis, and finally I can give a treatment and all the comprehensive care that is needed. So I have to prove that I have made the test, and indeed there is a benefit for the patients. You know that the treatments are always changing, or there is an evolution, you offered something different. So you have to be sure that the treatment is given, the comprehensive care is given to the patient too, but also that you can offer the best treatment, the new treatments and everything. So those are the bases. So is this applicable to sickle cell disease? So what is the purpose and the benefit of neonatal screening for sickle cell disease? That's the second question. We know that sickle cell disease is an inherited serious blood illness. And we know also that during the time that we are in the belly of our mother, we provide something what we call fetal hemoglobin. And at the time of birth, a little before, but at the time of birth, we will produce another hemoglobin, which is most often adult hemoglobin, but might be only hemoglobin S, which is the illness. And we know that the hemoglobin is something very important to be sure that we can breathe. Of course, we breathe through our lungs, but the oxygen has to go all in our body, in our brain, in our heart, in our muscles, everywhere. And during the time of the pregnancy, when we are a fetus, the mother breathes and she has the adult hemoglobin, while the fetus has to catch the oxygen from the mother. And this is why there is the production of this one, which is called fetal hemoglobin. But as soon as the baby can breathe, it produces an adult hemoglobin. And it's only at that time when we produce an adult hemoglobin that it could be something different, abnormal, which is called hemoglobin S, and then the illness appears. And since we know it's a serious blood illness, we of course will give a treatment. So this means that we know the natural history of the disease, and we know also that there is a pre-symptomatic phase for screening. As I told you in the beginning, we were a fetus, each of us, and what we had is a fetal hemoglobin. And at the moment of birth, we produce this adult hemoglobin, which might be abnormal. It's called hemoglobin S. So during this time, between birth and around 2 months of age, there are no symptoms, but what is very nice to know is that we can already detect the hemoglobin S by a test. I will show it to you after. And we know also that as soon as we have the majority of our hemoglobin, which is called hemoglobin S, we will have signs and symptoms like infection, painful crisis, and pallor, what we called as medical doctor, anemia. And we know also that we can do something during this period and all along. So we know that we can vaccinate the children, then we can give antibiotic to fight against those infections. We know also that we can give recommendation and parents' education to limit the painful crisis and some part of the anemia. We can also give a genetic counseling for the parents for the next children. And after a certain time, around 2 years of life, we will also try to prevent all cerebrovascular events, so in the brain, that could appear. It's also prevention through transcranial Doppler. So if you don't have a screening, sometimes the expression of the disease is not very important, and the diagnosis is made really late, and so you also don't have this possibility of prevention. So this is an example through a cartoon. You can give all the recommendation to decrease the painful crisis. Of course, you can give it to the child, but first of all, in the beginning, you will give it to the parents. And here it's, don't forget, some tips to avoid a painful crisis, like to cover up when it's cold, to avoid extreme heat, to don't give germs a chance, wash yourself well. You have to oxygen yourselves and go for walks, taking care to cover yourself. If you play sport, avoid sports that are too intense. Be aware of high altitudes. Avoid sitting too long. Your blood needs to circulate. Drink regularly throughout the day. And finally, go regularly to the doctor to follow your evolution. Warm him at the slightest problem, fever, or at the slightest question. So this is very important, and you can't give those recommendations to the parents if there is no diagnosis. And the first step might be through neonatal screening. For whom and how neonatal screening for sickle cell is performed, you might have antenatal screening, so it's for the couples. But what we are speaking here is the neonatal screening. So you have all of us, we have 2 genes to go to the expression of this hemoglobin. You have a normal gene, and you might have the disorder one. So the green one is the normal, and the red one is the abnormal one. If you have a mother who has only one gene, which has the disorder, we call it a carrier, and it's the same for the father. So what we pass to our children is half of yourself, if I can say. So you can pass the normal gene or the disorder one, and then the same from the father. And we know that our children are the mixture of our genes. So for example, you see here, the mother gives the normal gene and the father too. So the children is normal and not like their parents. And it might be amazing, but it's still your child because it's a mixture. And then you might have the normal one and the disorder one from the father. You are a carrier, or the opposite, the disorder one from the mother and the normal from the father. So you have also a child who is carrier of the disorder. And finally, you have the disorder one from the mother and from the father, and you have the disorder. And it can be detected at birth if the test is effective. And the screening can give you a precise therapy. Just to let you know that it affects both males and females. Okay, I just get this picture from a journey in Benin, and it was really very interesting to see that there was a centrum, a medical centrum, and all on the walls there were the different cartoon like this one, and I make a picture of one of them. And it was the purpose of it was to explain to the parents all the life and all the different aspects of the disease. And what I showed you before was on a disorder passed to the children by this way, and this is the same for sickle cell disorder. So you see here if each of the parents are carrier of the hemoglobin S, there is 1 chance on 4 to have a child affected by sickle cell anemia. But you have different possibilities, like the mother, for example, is carrier of the hemoglobin S, and the father carrier of hemoglobin C, and then there is also a possibility to have a child with a sickle cell disorders, which is quite different from this one, but it's also the disease. So you have the different forms, we have to know that and to explain it to the parents, and there is the clinical expression. So the screening must be really done in a way there is finally a correct diagnosis and followed by a precise therapeutic protocol. So who will benefit from the treatment and how? And then the screening is performed in view to find babies at higher chance of sickle cell disease, which is a serious blood illness. And who is at risk? In fact, all population were malaria. Malaria is a mosquito-borne infectious disease, and where malaria is or was endemic. So if you look at the map, you will see all the region here in yellow are the region where malaria is or was. So you know that in the Mediterranean basin, if you go to Italy, you don't have to take a pill to fight against malaria, of course, but a long time ago, malaria was there. And for example, in Sicilia, where the individuals were, there was less migration, effect of migration, so the sickle cell disease was really very well studied. But you see here also you have Greece, you have the south of Spain, and it's no more it is no more endemic for malaria, but nevertheless there was a mutation and the hemoglobin S or other abnormal hemoglobin appeared. So this is all the population at risk that we can screen. But of course, you know that there is an impact of immigration and the ancestry. So in Brussels, for example, people coming from certain region, like Italy, in Brussels or in the south of Belgium, they are from the 3rd or 4th generation, and sometimes we forget that the patients are coming from those regions where malaria was endemic. So it's not always so easy to say, okay, I have to point this population. And why this condition? I told you that someone can be carrier of the hemoglobin S. We say also that the sickle hemoglobin trait. It's another way to tell it. And all those people have an advantage, and they are more resistant to malaria infection. So for example, if tomorrow I go to Democratic Republic of Congo and I have no hemoglobin S, and I go with one of my colleagues who is a carrier of hemoglobin S, if both we go there in Kinshasa, for example, and we don't take a pill against the infection, the one who could die from the infection is me and not my colleague carrier of it. So it's really an advantage. But of course, as you saw before, if we have both parent carrier, unfortunately, there is a risk to have an affected child. So this is why, of course, that the ninth criteria is that the economic cost-benefit ratio must be assessed. So if you look in one of the publication here in 2017, you see that the frequency of the gene, of the abnormal gene, and the newborns with sickle cell anemia is varies a lot from one country to the other. And if we look at the European countries, it differed also. And this is why at the national level, the authorities look if a screening for the whole population has a cost benefit. I'm sorry to say so, but it's like that. And so if it will be applied like the other disorders that are screened at birth. How and where neonatal screening for sickle cell disease is performed. So there is an effective screening test that exists, and the screening test is acceptable to the population. So you can screen on the umbilical cord, but most often what is done is with the other tests that are performed at birth for hypothyroidism, for phenylketonuria, for example. And what is done, it's what we call a nil prick. So you have only a drop of blood, which is put on a filter paper. It's really like that, on a filter paper. And then in the lab, we can take this circle and we have a program, it doesn't matter, the analysis in the laboratory, and we can say, okay, the profile is totally normal or it's abnormal. And then we transmit the results. And as I told you before, there is a control. It's a screening test and not a diagnostic test. So other tests are performed to be sure that we can give a final diagnosis. In the screening, you can give only the results for an affected child, so a child, a newborn who has the sickle cell disease, or you can transmit also the results of the carrier. It will differ from the political strategy in each country. And why it could be interesting to also transmit the result for a carrier, it's of course for genetic counseling for the child, future family, but also for the parents, because if they weren't screened or diagnosed before, they might have a risk of having a child with a disease. So if you are not informed, you can't understand the situation and you can't take any decision. But in most of the screening, the purpose of the screening is to transmit a result of any baby affected by the condition. And here it's sickle cell disease. So when you have a positive test, you make the control with more tests. And then you, if the diagnosis is confirmed, you have the possibility to put the whole family in a comprehensive care management. And here you see that in Europe, there are different regions or country where the neonatal screening is applied. And most often it's universal. So I told you before that we know that there are several origin at risk. So the patient, the family coming from region where malaria, so this mosquito-borne infection was present, was really frequent. But since there are immigration, the mixture of all the population, it might be difficult to to ask many questions, and maybe you don't remember that your grandmother or grandfather is coming from somewhere at risk. So most often it's universal, unless in France is targeted to the population at risk, and so they ask to the mother and the father what is their ancestry. So this is the end of my talk. So the message that I wanted to share with you is the screening means to test a group of individuals for severe disease while a treatment is available. And if positive, further tests are done to give the final diagnosis. Then making the diagnosis of sickle cell disease early in life is important. It makes possible to prevent serious events. The frequency of sickle cell disease varies greatly from one European country to another. See migration of people from European or non-European countries where malaria infection is or was endemic. And screening for the disease is simple, effective, and not dangerous. It is implemented in several European countries where it has been proven to be cost effective. And it's open to the discussion.
Thank you very much, Professor Gulbis, for this very clear presentation. And as said during my introduction, now we have a moment dedicated to the questions. If you prefer to raise the question orally, you can raise your hand, or you can unmute yourself and take the floor. That is also maybe easier than raising the hand on Zoom. Or if you prefer, you also can write the question in the chat. And as I always said, this is a unique occasion for talking directly with such an expert on the subject. So I really encourage the audience for commenting.
Yeah, probably I missed something, or you would like to know something more specific? Or it's totally clear and that's it.
Or also it could be on the other way around, that we can maybe ask to the audience according to the country if they have a neonatal program, or if
how they were informed about it.
How they were informed could be also interesting. So I can see the first question. When can we expect universal newborn screening to be implemented in France, given the highest incidence of sickle cell disease in Europe?
Yeah, so of course I'm not in the place of the authorities in France, but I know that the way they see it is the fact that most of the cases that were missed were the cases because of administrative problems. So administrative problems means that you or just the screening by itself. So if you don't screen the baby because there is so the birth was not what was done in an emergency, and then you were not in the right environment, so you can miss it. Also, the way you miss it because you mix the name of a baby, that could be, but it's more than that. It's most often they say, okay, there is let's say 1,000 newborns in a certain maternity, and in fact 10 babies were not screened because of different aspects. So they say it's the most important problem, and this is why they say that they never really could show that the fact it's targeted was not a good way to perform it. And I think it's also related to the economical aspects, so the cost benefit. But I understand that yeah, it's a way, it's a choice, and you say I always like to think in a positive way. So in Belgium, while the frequency of the disease is very high, we have a screening only in the region of Liège and the Brussels region. So I think that in France, at least, you have a screening all over the country, and this is more than nothing.
Thank you very much. Okay, so let's see if
I have a question. If someone can answer to me, how do you see the impact of the patient association to push the authorities to perform a neonatal screening where it has a cost-benefit, economical cost-benefit aspect? I don't know if someone would like to. And maybe in France, I'm sure that the patient association had a very strong impact with the implementation of the neonatal screening. So how did you do it? Or can we maybe give any advice to the other EPACs in other countries? I don't see the chat if someone would like to react.
Yes, or as said before, you can unmute, and we have one answer. In Portugal, since February 2022, we are doing a 2 years pilot test nationwide after a 1 year pilot in the second highest incidence areas.
Yeah, we did it also in Belgium. So we gave the authorities the frequency of the disease, and so during 6 months we performed the national screening, and even with that we didn't succeed. And I really think that we need the patient association to help us, to help not us, because it's not for us, it's for the children, of course, to be sure that they can be entered in a comprehensive care. And for example, we had the opportunity in Belgium to understand that we could compare the newborns screened in Brussels region, for example, with those who were not screened, because we have a national registry with the patient, and we couldn't understand that even if everything is evolving, there are the new vaccination and extended vaccination process, but of course you don't give antibiotic therapy to all the children. It is really a benefit to have the neonatal screening. So still.
So I can read this comment. I believe there is universal screening for cystic fibrosis when it's less prevalent than sickle cell disease in France. So the lack of universal screening here could be perceived as unethical and discriminatory by patients and patients' advocacy groups. Yes, indeed.
So I think we can also say that it's good to know that patients with cystic fibrosis are screened and then have a diagnosis. I think it's important. So I would say, okay, it's very good for the cystic fibrosis, just to if we speak about sickle cell disease, we would like to have something also universal. I don't think it's necessary to compare.
I can see one hand raised. Miriam, if you want, you can unmute yourself and take the floor.
Hello. Yes, it was really nice and very informative. Thank you very much. I think it's probably the presentation that I've seen that is very, very clear for even those, because usually they are very, how can I say, technical. So it's not easy for someone who is not a professional to follow it. This one is really accessible. So thank you very much for that.
Thank you. Thank you. I try that.
Okay, so that's good. I wanted to ask something. So I've noticed in the chat, I have provided some very small piece of information about Portugal, because you mentioned if we would like to share that. It's still in a pilot stage, because they are gathering information to see if it will indeed be included in the national program of the neonatal screening, as far as I understand. I'm probably not the best person to talk about that, but I can gather more information on that. I noticed that Antonio from Spain wants more information. So Mariangela has my email. So if Mariangela, if you could share it, then fine, I will find the information that Antonio wants, or whoever else wants, and more, how can I say, that is not misleading, which is the correct information, because sometimes it's difficult to find that. I wanted to ask, because I noticed that there was a presentation in Portugal last year when they moved from the 2 highest prevalence districts to nationwide. There was a presentation that they made. And one of the questions that was raised was about what happens with the information about the traits only. Because, for example, I was checking here, the information that they gave is that from those 2 districts, so one is the capital, Lisbon district, and the other one is Setúbal, which is south of it, and which corresponds, it's much similar to the Mediterranean basin. So it's a basin, it's a big area with rice fields, where there was a big migration in the beginning of the 20th century or something. And so it was the same thing with malaria. So there is a big concentration there, right? And so they said that in the 9 months pilots that they ran in these 2 districts, they tested about 23,000 babies, with 25 babies having sickle cell disease. So probably there were more just with the traits, but there were 25. What I'm asking is if you have any information on what happens or how is the information treated, meaning if you have, let's say, I don't know, 500 with a trait and only 25 with a disease, is it only the 25 with a disease that are relevant, or what happens? Thank you.
So, if you go to the purpose of the neonatal screening, it's only to give the results of the disease. It's the same for the metabolic disorders, and you only give this, and this is really the purpose, and they focus on that. But of course, we understood that the trait, maybe for sickle cell disease, something different, because when you have the trait, since we have many newborns with the trait, we can, for me, I was really happy to inform about it. Of course, you can say, okay, the parents are afraid, they don't understand, but I'm not sure of that. If you take your time and you give a correct information, I think it's interesting, and it's also too interesting, as I told you before, for the parents, so they know that they are carriers and maybe there is a risk for the next child. So that's important, and that's important for the child too when he will be old. But maybe we'll have a treatment since then. I don't know. But also, it was really powerful to inform all the nurses, the medical doctors about the disease. And to me, it was really very interesting, yeah, to inform about that, because the expert center are not always known. And so to me, it was really something important. But the choice is related to the way the authorities would like to spend the money, because of course, if you have to give such a huge amount of tray, yeah, it needs something very well organized and more power put in that.
Thank you very much. Until now, there are no more other comments nor questions in the chat. But please do not hesitate to unmute yourself and take the floor, as said.
I've got a question. Doc, somebody was saying that in France, no, even you started saying sometimes it's because of financial constraint or something that they don't particularly do the screening. And you mentioned about France, and somebody mentioned about the fact that they are screening more the other disease. And because there are more sickle cell patients in France than that disease, and you said they can't compare. Why can't we compare? Because this disease has, well, compare the people, more people of Black nature have the disease than white. So the policymakers, everybody in power, they are not thinking about sickle cell, but they will think about something that can affect their family members. So if you're talking about it, let's be clear and call it how it is. Why are they not screening more Black people or sickle cell patients in France? I know we are not talking politics here, but at the same time, you can't say that is good. So we can't compare. It's good that they are screening, yes, but why are they doing more for, is it, sorry, I can't remember the disease that the person mentioned.
Cystic fibrosis,
That's it. Yeah.
But you know, what they do, of course, it's not a political flora, but what we know that in France, in the downtown, where there's a huge amount of patients at risk, they do a universal screening. So yeah, and they try to all over the year. They really try to see if too many cases are missed, and yeah, that's a way to do it. I can't criticize. As I said before, I think that it's better than in any countries where there is no screening at all.
Yes, it is. But if the facilities are there, then we must encourage. I know you said something good, like the patient, we should advocate, we should push for change.
That's what I really think, that you have to advocate, and we have I had cases with I remember a family, and the husband was from Belgian ancestry, but the abnormal hemoglobin was something different, and the wife, it was a long time ago, it was the 5th ancestry, as I remember, with hemoglobin. So the couple was really, they were white, as you said before, they were white, and even if they were not screened, they were not screened. That's it. So I think that we have to work together as medical doctors, and in parallel, and both in the same way, to push the authorities to understand what's important, what we can do, and how we can proceed. And this is why I ask you, how do you see the way that the patient association can help to push the neonatal screening in every country where at least it's reasonable to propose it for all the newborns?
Thank you.
Thank you to you too.
Thank you to both of you. So I think we have the time for the last question or comment, if any. Okay. Then I think we can close the session. Before that, I would like to inform you that the next webinar, that is on gestational risk, was foreseen for the 6th of June, but it has been postponed to the next week. So it will be held the 13th of June with Dr. Laura Joseph, so gestational risk. And so, well, thank all of you for being here. Most of all, thank to Professor Gulbis for having shared with us in a very clear way her expertise and her time. And thank to all of you for the debate and the share of idea and input. Thank you very much. So I hope to see you on the next session in 1 month.
Thank you very much. Bye.
Thank you. Bye-bye.
Bye.
Thank you. Bye.
Bye-bye.